and good day to many of you. I'd like to welcome you to our virtual program this evening, Managing Melasma, Advances in Diagnosis and Treatment. If you have questions during today's event, you can enter them in the Q&A box, and if you encounter any issues with your connection or experience delays with the slides or video, please refresh your browser window, as this will often fix minor issues. Google Chrome is the preferred browser. Today's Roundtable on Melasma is the inaugural program for Candella's new 2021 educational series on skin of color. Through the course of this year, we have several other excellent programs in this series. Our next programs will also be case-based approaches to treating a wider range of pigmentary disorders, followed by other programs, including a brand new program on laser complications and how to both avoid and treat them. All of our programs will feature international experts and focus on sharing their practical and clinical experience. Please note that registration links will be up shortly at candelamedical.com/NorthAmerica/events. However, they are not up just yet. Those of you that are registered, of course, for this webinar will be the first to receive registration links to your inbox. At that point, simply click on the link in the resource window on your console. With that said, I'm pleased to introduce Dr. Gili Munavalli, who will moderate today's program. Dr. Munavalli is a board-certified dermatologist, fellow of the American College of Mohs Micrographic and Cutaneous Oncology, and the American College of Phlebology. He is founder and director of dermatology, laser and vein specialists of the Carolinas and Charlotte, North Carolina, and also serves as assistant professor at the Wake Forest University School of Medicine. So without further ado, Dr. Munavalli, I will hand this over to you.
Okay, thank you, Dr. Shellen, and thank you to everybody for joining us from all over the world. And it's actually very timely that we have people from all over, because our faculty is literally from all over the world tonight, and we wanted to represent how we view melasma in our patients and treatment options from many different views. And we are very fortunate to have this faculty here tonight, and fortunate that Candela was open to talking about the medical and procedural or laser aspects of how to diagnose, manage, and treat melasma. So I'm going to introduce the faculty, and I'm sure many of these dermatologists you already know very well. The first one who will be speaking tonight is Dr. Simul Desai, who's a board-certified dermatologist and an internationally recognized expert in treating skin of color and pigmentation, with melasma being on top of the list. He's founder of Innovative Dermatology near Dallas, Texas. And he's also focused on the mission is focused on skin disease and skin of color. He's the immediate past president of the Skin of Color Society and on the board of directors of the American Academy of Dermatology. He also represents us at the U.S. Food and Drug Administration for various issues that have come up, including most recently the use of local anesthetics in the office. He's also in academia. He's a clinical assistant professor of dermatology at UT Southwestern, the Medical Center in Dallas. Our next colleague is an old friend, Dr. Paul Friedman, who is currently the vice president of the American Society for Lasers in Medicine and Surgery. He's also Mohs trained and laser trained, and works as the director of the Dermatology and Laser Surgery Center of Houston, Texas. So both of them are braving the weather and the snow issues, power issues, to join us tonight, and we hope that the power stays on for them. It's been a long week. He practices also in Laser and Surgery Center of New York, where he's been there for many, many years seeing patients. So he has 2 offices and sees 2 different populations of patients. Our next colleague dermatologist tonight is Dr. Ariel Klavar, who was recently awarded the Leon Goldman Award by the American Society of Lasers in Medicine and Surgery in recognition of her excellent research, patient care, education, which is related to medical lasers, and she has educated us all through textbooks and numerous publications. She's also trained in Mohs surgery and also has an interest in pigmentary disorders. She's founder and director of the New York Laser and Skin Center, and as I mentioned, has edited and and written numerous book-to-book chapters on topics of laser surgery and cosmetic dermatology, as well as skin cancer. We are very pleased to welcome tonight Dr. Rashmi Sarkar, who's joining us from India, and we're very glad to have her with us, speaking about her experience with melasma, which she's published innumerable articles and lectures. She's professor in the Department of Dermatology at Lady Hardinge Medical College and Associated Hospitals in New Delhi, India. She also serves currently as the president of the Pigmentary Disorders Society and is an internationally renowned authority on treating pigmentary disorders. As I mentioned, she has published extensively with over 250 publications to her name. Last time I was in India, actually, it was very fortunate to see Dr. Sarkar speak in Bangalore, in India. She's a passionate teacher, lifelong member of the International Society of Dermatology, who has mentored hundreds of students across the world, and that passion shows in joining us tonight for this talk. So these are our relative conflicts of interest or disclosures for this talk tonight. And our first speaker, as I mentioned, will be Dr. Seema Desai from Dallas, Texas. And Seema, I'll let you take over on the controls. And again, thanks to everybody for joining us tonight.
Well, Gilly, thank you very much for that very kind introduction. And it's such an honor and a privilege to be with such an esteemed group of panelists. And special thanks to you, Dr. Munawali, for putting together this program and bringing us together even in this virtual setting, and to the team at Candela for giving us the opportunity to talk about a disease that I'm very passionate about, and I know my panelists feel the same way, and you'll hear from all of us this evening. Just for additional disclosure, I am required to disclose, as Dr. Munawali mentioned, that I serve on the U.S. Food and Drug Administration, specifically in the world of compounding. I'm a voting member of that committee, and I'm required to disclose that. Much of what I'm going to talk about tonight has nothing to do with my FDA role, and it will have some impact on some of the melasma and pigmentation research that I do in my practice. So some of this will be off-label, but I did want to give you that disclosure prior to talking. And I thought, what better way to set the stage for what we're going to talk about tonight in melasma than to really talk about why pigmentary diseases are such a passion for me, but I think why they're exceedingly relevant in all of our practices, no matter where you practice dermatology or aesthetic medicine. And I thought that this snapshot of a front page view of the BBC's Health homepage that was published a few years ago really tackles something that I have found pervasive in my patients of color, which is a continual emphasis on how pigmentary disorders have a profound psychological impact relations to one's own identity. And I think all of the speakers would agree that many of the patients who come to our practices, particularly to my practice in Dallas, where I serve almost an exclusively skin of color population, the melasma pigment diagnosis is one that is oftentimes linked to anxiety, emotion, stress, and really transcends a lot of what these patients are experiencing, not just what we're doing with the art of medications and devices. And this was a really fascinating article that was a social media campaign really trying to target the fact that we as board-certified dermatologists and physicians should be empowering our patients to know that pigmentary diseases are indeed an important part of one's own identity, but they don't define who you are as a person or as an individual. And I think that's something important to keep in mind when we talk about all of our therapeutic armamentarium and advances. And this is a really busy slide, and it's busy on purpose because this sort of highlights how complex melanin or pigment production is in the skin. And I think that's one of the things that I hope you'll all take away from tonight's program, which is that melasma is an incredibly complex disease. And it is a disease. This is simply not an aesthetic condition. I have many patients who come to see me who've seen other fantastic colleagues in dermatology, great doctors, great physicians, probably not super interested in treating pigmentation, so they end up coming to see me. And the dialogue that we have with these individuals is to let these patients know that melasma is a chronic skin disease, very similar to having atopic dermatitis or psoriasis, or even having any other chronic health disease like diabetes or hypertension, meaning that is something that we as experts can help the patient manage and get better, but we're not going to ever be able to cure the disease, because no matter what happens to the visual impact of the pigment, we know that there is exceedingly very common and complex pathways happening always under the skin, specifically related to enzyme activity with tyrosinase, specifically related to melanosome packaging, and also UV and environmental factors that can cause the pigmentation to come back. And I think all of you would agree, you've had patients, you get them better, they're super excited, they even give you a great online review, and these patients that are lost to follow-up for a year or a year and a half or 2 years, and then they end up in your office one day after a beach trip that they've gone on where their melasma has just come back with a vengeance, and they're in your office in tears thinking, why did it come back? Why did it not stay away? And I think setting expectations up front that the disease process itself is something that can be managed and improved, but is never going to be 100% gone, is something that is very critical to ensuring treatment success and making sure you have that rapport with that patient, particularly one with skin of color. And I briefly want to mention that in our knowledge of pathogenesis of melasma, some of the newer work really revolves around the fact that there are metabolic and underlying factors, not just melanin. So that busy slide that I just showed you that talked about melanin production because of increased enzyme activity, that talked about packaging errors in the melanosomes. All of that is happening. But the other components that are happening that we also need to learn to tackle, both therapeutically and with devices, is based on vascular characteristics of melasma, which has been shown out of great studies done in Southeast Asia, particularly related to increased VEGF or vascular endothelial growth factor that's causing background dilatation of those vessels. How many of you have treated a patient with melasma? You get the brown better, and then once the brown's better, you unmask almost this pink rosacea ruddiness on the cheek. And many years ago, when I started my journey in learning about melasma with my mentors, we often thought that that was due to potentially the topical steroid component of a triple formulation cream, kind of causing that steroid-induced telangiectasia erythema. In fact, that's probably not true. It's probably that you're getting the melanin better and you're unmasking this vascularity. So there's a lot more to be said and done in this work. As there is specifically in other underlying endocrine metabolism issues, specifically thyroid disease. Now, we talk a lot about thyroid. If any of you heard my vitiligo talks, you know I talk about that a lot. But thyroid dysfunction has been linked to patients with chronic melasma. So does every melasma patient who come into my office get a thyroid lab slip to go down to the lab and get a thyroid checked? And the answer is no. But if I have a patient who I've tried medical therapy, who I've moved then into physical modality like peels or maybe even lasers and combination treatment, which my colleagues will talk about, then yes, I will check a thyroid dysfunction test, specifically a thyroid stimulating hormone and a free T4. And you'd be surprised that many of these patients do have underlying thyroid disease. So the point of me giving you this little bit of a pathogenesis update, if you will, is to think outside the box when we're treating these melasma patients. Chronic disease that's not curable, that you're going to help get better and guide the patient in their journey. And that's what we really need to empower these individuals to understand. And I think our therapeutic ladder includes all of those things. Melasma is not something that I ever tell my patients is a one-time treatment or a one therapy treatment. This is a disease that requires multiple modes of therapy, everything from a sunscreen down to topicals, to chemical peels and cosmeceuticals, and the list goes on. And some of those things I've listed here for you on the slide. And we'll review a little bit about topicals in my remaining few minutes before I turn it over to my colleagues. Now, one of the things that I want to mention is that in my practice, hydroquinone-based triple combination therapy is still the gold standard in terms of topical skin lightening. And what do I mean by that? What I mean by that is the combination of a topical retinoid, steroid, and hydroquinone combination. Now, I have my own compound that I make and that I formulate for my patients, and you can get that done at a variety of compounding pharmacies in the US or in your country that you're tuning in from, or you can even write proprietary or branded formulations. The point of this paper that I wanted to show you on this slide is that this is one of the best papers, in my opinion, that exclusively studied skin of color individuals and showed that monotherapy treatment of melasma with only hydroquinone is inferior to using a triple combination therapy. And the take-home message for me in this, and what I share in a lot of my speaking that I do on this, is unless you have a contraindication to using a retinoid and a steroid with your hydroquinone, there really is no reason, in my opinion, to use hydroquinone monotherapy. You have someone who's allergic to a retinoid or prone to retinoid dermatitis, fine, talk about that with the patient. But unless you've got a legitimate reason to exclude the retinoid and steroid, you really want to have the synergy of those ingredients together. Now, with that, though, comes the discussion about hydroquinone safety. And I think that discussion should be had with every patient. It should be had multiple times with every patient. It should be documented in your discussion with the patient. However, I really want to empower my patients to not be afraid of hydroquinone from what they read on Instagram or on Google or in the New York Times, where hydroquinone and even dermatologists have been labeled as giving patients drugs that cause cancer for their pigmentation concerns. Hydroquinone has never been shown to be carcinogenic in human subjects. And it's important to know that hydroquinone has been shown to have no long-term toxicity if used in a very controlled, systematic fashion. And I think if you take the time to discuss a rotational algorithm approach to therapy with your patients, remember what I said, it's a chronic disease. So does that mean that the patient is ever going to not be using something for their melasma? The answer is no. In my practice, I have patients start triple combination hydroquinone therapy. They stay on it for 12 to 16 weeks for me to calm down the condition and improve it. And then I rotate them off the hydroquinone and use other things that I'll allude to here. Because if you don't do that and you continue to use hydroquinone, you end up with a patient like this, which is someone who was using 8% hydroquinone topically for over 15 years and ended up having this condition, which once you have it and you see a case of it, you'll never forget it, which is exogenous ochronosis, one of the rare but very challenging side effects of long-term unabated hydroquinone use. So the message really is to avoid something like this. Counsel your patient, empower and educate your patient, document your discussion, and use your hydroquinone when you need it. And what I tell my patients is when melasma is happening in your skin, think of your skin's pigment cells as running at the speed of a sports car engine. Your skin's pigment cells are kind of like a Porsche. And my job is to turn that engine down and make it into a kind of like a Hyundai or a Kia that's just kind of sputtering along. And so revving down that engine speed is what hydroquinone does, along with other skin lighteners. But you still have to maintain that engine speed so it doesn't start to go in super speed again and make too much pigment. So hydroquinone safety is an important discussion, but in terms of our topicals, still really remains the gold standard when thinking about focused, systematic use of the product. Now, azelaic acid is another topical that I love to use. I use it all the time off-label. I use it usually in 20% concentration, and I oftentimes get it compounded with kojic acid, but you can use this as monotherapy alone. Many of our colleagues who are joining us tonight have even published on this. I love azelaic acid, especially for my patients who potentially are in their postpartum phase or potentially wanting to get pregnant or nursing. This is a discussion that I have with the patient and oftentimes even with their obstetrician. But azelaic acid is something nice once you rotate the patient off the hydroquinone therapy. And guess what? You can use azelaic acid for a very long period of time along with sunscreen and cosmeceuticals and try to maintain that pigment from not coming back with a vengeance. And if it does, then you go back to your strong hydroquinone and pull out your big guns again if you need it. I also wanted to briefly point your attention to this ingredient. My disclosure being I've helped develop this ingredient. Actually, Rashmi, who's on the call, she and I worked on this in India. Kojic acid dipalmitate is a interesting variant of traditional kojic acid. It's actually a UV light and pH stable form of kojic acid that's really nice because it allows the patient to use this for a longer period of time without it being degraded by outside UV and high non-SPF protected exposure. And this happens to be a picture of Japanese koji rice, which is very fluffy grain rice, and that purple grayish look is the Aspergillus species that grows the kojic acid dipalmitate on the surface. So this is an interesting ingredient that's available globally for those of you tuning in internationally in a variety of forms in non-hydroquinone based skin lighteners. Vitamin C, I just wanted to make a comment on that because I do use a lot of vitamin C in cosmeceutical formulations for my patients with melasma. Again, is it a monotherapy? No, but remember, melasma is not a monotherapy disease. So you combine ingredients together, and I actually find vitamin C to be really nice in some of my cosmeceutical forms that we dispense in the practice. Now, briefly in closing, I wanted to point your attention to this article we published in JDD about a year and a half ago. And the reason I want to point your attention to this is I get lots of questions on tranexamic acid. And my colleagues are going to discuss this in more details later. But since I'm focusing on topicals, I want to point out that topical tranexamic acid has become a very important part of my therapeutic armamentarium of these multiple agents that I use when trying to get patients off of hydroquinone. And usually 3% tranexamic acid in this formulation that I helped develop, it's a cosmeceutical. You can also get it compounded. And this study was the first study that we did. It's actually the first study in the literature that shows that tranexamic acid technically works as an anti-inflammatory in down-regulating the production of melanin. And the reason it does that is if you look at these human epidermal melanocytes that are that sports car engine that I told you about, the melanocytes that are always working in overdrive, they produce a lot of prostaglandin E2. But notice when you add tranexamic acid to those melanocytes, it brings down their melanin production down to a level of just any old normal melanocyte from a non-melasma patient. And this was really the first time that was shown in vitro that tranexamic acid helps reduce melanin production specifically via down-regulating prostaglandin production, which is a pro-inflammatory cytokine. So keep that in mind when discussing that. And finally, for those of you who are interested in thinking more about non-hydroquinone-based options, there are other ingredients that are now being developed. This happens to be one that I've worked on in clinical trials called cysteamine, which is an amino acid derivative of the naturally occurring and dietary source amino acid cysteine. In fact, if you had an omelet for breakfast, you probably consumed a good amount of cysteamine derivatives this morning. It's also high in content in human milk. But cysteamine has been shown as a very interesting inhibitor, again, of not just that one tyrosinase enzyme step, but multiple steps in the pathway. And so I think the message in topicals is that we've come a long way, and there's a lot more happening in our journey. There's a lot of studies that have been published. If you're interested in reading those, the Blue Journal and the British Journal are two of the ones where cysteamine and other botanical ingredients have been published. And I think there's more to come in our journey when we combine and layer these ingredients as we lessen our dependence on hydroquinone. And with that, I'd like to turn it over to Dr. Kovar and Dr. Munavali.
Thank you, Simo. Just before Ariel speaks, I wanted to let everybody know at the end of the talks, we're actually have probably 8 to 10 really good cases that the panel is actually going to walk you through on how they approach treating. So I really, when we're talking about these therapies, keep that in mind because we will be referring to those later on. So with that, I'm going to turn this over to Dr. Kovar, and thank you, Ariel, for joining us tonight from snowy New York City. Yes.
While we wait for Dr. Kovar, maybe we can take a question or two.
Oh, here I am. I'm sorry.
Oh, there she is. Okay, there she is.
I'm so sorry. Thank you, Dr. Munavali, for that kind introduction. It's an honor and pleasure to be speaking to you this evening about melasma, along with this international panel of expert dermatologists. As you've heard, melasma is an extremely challenging disorder to treat, and it's also very common. In some populations of females, it can affect up to 30–40% of women. And it's a chronic disorder, as you heard from Dr. Desai, and there are multiple etiologic factors, including abnormalities in pigment, vascular abnormalities, and these patients also have epidermal barrier dysfunction, which sometimes makes it difficult to use all the various topical medications, which can sometimes be irritating. In addition, melasma patients are highly sensitive to not only ultraviolet light, but also visible light, and in some cases, infrared light. And they're also highly sensitive to inflammation, whether that's from overly aggressive laser treatment resulting in thermal damage, or a strong chemical peel, or even topical agents. And as you heard, melasma results in documented psychosocial and emotional effects and quality of life issues for our patients. Although melasma is quite challenging to treat, helping patients with melasma is also extremely gratifying. This patient here comes to see me every few years, and we're able to clear her up, and she has a prolonged remission. And in this case, her last time that we saw her, we treated her with a picosecond Nd:YAG laser, the PicoA 1064 nanometer laser. She had 2 combination treatments with microdermabrasion and with topical therapy, and you can see that she's nearly clear after these 2 treatments, and her remission has lasted for a minimum of 8 months. It's important that we treat our patients holistically because of the multifactorial etiology of melasma. So as you heard from Dr. Desai, they are overproducing melanin all the time. This results in a buildup of melanin in both the epidermis and the dermis. In addition, there are vascular abnormalities. These patients have an increased network of telangiectasia in the dermis, both larger diameter vessels and a larger number of vessels. And so we have to treat all these different components of melasma to get effective therapy. So it's important to counsel the patient about their triggers and understand their natural history of melasma, what they have tried, and what their response has been. When evaluating a patient with melasma, it's also important to have an objective way of imaging their melasma and managing their response to the treatment. So all of the patients that we see in our practice get standardized digital photography. We also do ultraviolet photography, and it's helpful to follow these patients with dermoscopy as well in a way to monitor them. I like to use a 3-pronged approach for those patients who have failed a conventional therapy with topicals, and that is combining skincare and topical therapy with a physical exfoliation using microdermabrasion and laser therapy. In terms of skincare, I like to use a physical block containing iron oxide. The reason for this is physical blocks are not irritating, and we know that these patients have barrier dysfunction and very sensitive skin. With a physical block, we can block both UVA and UVB, and multiple studies have shown that iron oxide is also helpful in blocking visible light, which there's now evidence can impact melasma as well. And we use a topical regimen to suppress melanin. As you've heard from Dr. Desai, hydroquinone is the most effective molecule, but we can use multiple others, including kojic acid, arbutin, ascorbic acid, and retinoids singly or in combination. While the triple combination therapy using corticosteroids, tretinoin, and hydroquinone is a tried and true way to get melasma under control, I like to avoid this and use retinoids and hydroquinone and only use corticosteroids immediately post-procedure. And the reason for this is that I find that corticosteroids will often mask irritation from these other molecules, and patients will often develop a dependence on that. And we all know that long-term therapy with corticosteroids can lead to atrophy, and in the case of melasma patients, often rebound because they develop an increased vascular component or telangiectatic component to their melasma. The microdermabrasion serves to eliminate the epidermal melasma because of the increased epidermal turnover. And really, where we've been able to really advance the treatment of melasma is with adding laser therapy. And we've had a number of advancements over the last 2 decades, first with the short pulse nanosecond Nd:YAG laser, and more recently with the ultra short picosecond laser. And what the advantage of these lasers is, we can use very low energy, so low that the patients don't feel it, they don't become red after treatment, they don't need topical anesthesia, and we do this with very low energy, low pass number, and not more than 1 treatment a month. And we can disperse dermal pigment and eliminate the pigment without causing inflammation or thermal damage. Another intervention with lasers is that of low-energy non-ablative fractional lasers, and you'll hear more about that from Dr. Paul Friedman in the next talk. And he'll also be discussing the importance of treating the vascular component of rosacea. In my practice, when a patient has a clinically prominent vascular component, I will also add vascular laser therapy. So do the combination of microdermabrasion, nanosecond or picosecond laser, and then a vascular laser all in one session. About 10 years ago, I published a report looking at the effect of very low fluence Q-switch Nd:YAG laser treatment in combination with the microdermabrasion and topical therapy. And we were able to show that after just 2 to 3 treatment sessions, over 80% of patients had greater than 70% clearance of their melasma, and they were able to maintain very long-term remissions from a minimum of 6 months to as long as 18 months post-treatment. And this is one of the patients here who underwent 3 treatment sessions. In more recent years, with the development of the picosecond technology, I've now incorporated picosecond laser into my therapeutic armamentarium, using it in the very same way, very low fluence treatment, limiting it to 2 to 3 passes and not more than once a month treatment. And when there is a clinically significant vascular component, I will also add a vascular laser, which could be a pulse dye or a post-KTP, with pulse dye being my preferred modality. And this is an individual who had 4 monthly treatments with a combination of the 1064 nanometer picosecond laser and V-beam pulse dye laser, along with their topical therapy, with a nice improvement. One cannot talk about short pulse laser without mentioning guttate hypopigmentation. This is a very serious side effect from overuse of nanosecond or picosecond lasers. In Asia, in the last 10 years, it's been very popular to perform a procedure called laser toning. It's described in the literature as being low fluence, but the fluences are really moderate. And in addition, patients are often treated with 10 to 20 passes of the laser in a single session, and they're treated at weekly or bi-weekly treatments. And so the cumulative laser dose to these patients is extraordinarily high, and what happens is you get irreversible damage to the melanocytes or the pigment-producing cells with resultant permanent depigmentation, as you see in this individual. Nonetheless, to my knowledge, use of the very low fluences, large spot size that I'm describing with just 2 or 3 passes and monthly treatment has not resulted in any cases of guttate hypopigmentation. In terms of managing our patients, as I mentioned, having an objective measurement is important. So in addition to standardized photography, which we perform at every visit and look at it in conjunction with the patient, I also sometimes use dermoscopy, which could give you a good indication of the amount of epidermal and dermal melanin, as well as the vascular component. Since the patients do have variable tolerance to skincare, I curate the skincare regimen specifically for each patient. We monitor them for irritation. We gradually incorporate each product over a series of a couple of weeks, and the patients will call us if they have any dryness or irritation, because developing dryness or irritation will exacerbate their melasma. Fluence is very important. And with our picosecond and nanosecond lasers, it is possible for the calibration to go off kilter because these lasers have a series of mirrors in the articulated arms. And someone can tell if you're using too high or fluence by the amount of pain the patient is having. If they're complaining of pain, and typically we use no topical anesthesia, or they have hair whitening of their vellus hairs, or production of erythema at the time of treatment, then you need to lower your fluence. Immediately post-treatment is when I use a topical corticosteroid, and we also have them iced for 10 to 15 minutes after each laser treatment. In my practice, most of the melasma patients that I see have already failed conventional therapy with topicals. But the takeaway points here are, whenever you're meeting a melasma patient for the first time, perform an exam, take an extensive history, understand their exacerbating factors, do standardized photography and dermoscopy, and you will maximize compliance with good counseling, explaining to them the role of sunscreen, the role of topicals, the role of lasers should they need it, and that this is a chronic disease. They will likely have exacerbations, particularly during the summer months. And if they haven't had an adequate trial of a topical regimen, I will certainly do that as a first line treatment. If they have not achieved an adequate response, we then move on to 1 to 2 monthly laser sessions. Typically, if they're going to respond, you know that within 2 treatment sessions. And if there's a poor response to laser, that's when I move along to tranexamic acid, and you'll hear more later in this session from Dr. Sarkar on the use of tranexamic acid. So while melasma is a chronic disorder and it cannot be cured, it can be managed, and importantly, we can improve the quality of life of our patients. And multiple studies have shown by reducing their pigmentation, we can improve the quality of their life on validated scales. Remember, both for physicians and patients, that melasma has a multifactorial etiology. There are pigment and vascular abnormalities. Patients are sensitive to visible, ultraviolet, and infrared light. They're sensitive to inflammation, and adequate control requires combination therapy and a customized approach for every patient. Thank you for your attention.
Thank you, Dr. Kovar. We're just going to pause and take a couple of questions here. And a question for you is, would you elaborate on some typical pulse dye laser settings and Pico 1064 settings that you may use for melasma?
Sure. So the pulse dye laser settings that I like to use is a 10 millimeter spot, 10 millisecond pulse duration, and a fluence of 6 joules per centimeter square. If I'm treating someone with type 4 or light type 5 skin, I will drop the fluence on the first treatment to 5 joules per centimeter square. With the nanosecond laser, I tend to use spot sizes, or the Q-switch Nd:YAG laser spot sizes of 6 to 8 millimeters with fluences of 1.5 to 2 joules per centimeter square. And with the picosecond Nd:YAG laser, I like to use spot sizes of 6 to 8 millimeters with fluences of 0.6 to 1.2 joules per centimeter square.
Thank you. That's very helpful. And one more question is there a treatment, or what treatment do you recommend for guttate hypomelanosis?
Well, that's difficult. What I try, and this is true for all sort of deep pigmented type of lesions, is I find the most useful treatment is actually a fractional CO2 laser at low energy and low density in conjunction with repigmenting agents such as bimatoprost. And immediately, so we do laser drug delivery. We create little channels with the fractional CO2 laser. put on some solution of bimatoprost, and then the patient continues to apply that twice a day. I also will apply a corticosteroid along with the bimatoprost immediately after fractional CO2 laser treatment.
I have a quick question for Ariel. When you're doing subsequent treatments, we're talking about laser toning because I think that's a treatment that's done worldwide using both Q-switched and picosecond. In subsequent treatments, and we know these treatments take, sometimes 6 to 8 to 10 treatments, or sometimes at least 4 treatments to see some benefit. What is your rule for increasing the fluence, or do you stay at a given fluence? How do you manage that going from treatment to treatment?
So I never increase the fluence, and I think that's where people get into trouble. If you're not seeing additional clearance with additional treatment, then that would be the point at which I would consider tranexamic acid. I think the issue is that if you start increasing your fluence, increasing your pass number, then you are increasing the risk of guttate hypopigmentation. I tend to decrease the fluence more often than increase it. For instance, if a patient has very dark pigmentation, they will have more target for laser absorption. And so they'll actually need a lower fluence than someone with lighter skin and more scant pigment. And I let the patient's sort of symptomatic response be the guide. So if they're having pain with a fluence that I typically use in other patients, then I want to turn down my fluence because there's too much absorption.
Okay, thank you. We're going to go, at this point, we're going to transition back to Texas to Dr. Paul Friedman. And Paul's going to speak about his experience with melanoma. Houston, we have a problem. Paul, go ahead. Thank you.
Thank you, Dr. Munavalli, for the kind introduction. It's an honor to be among this esteemed panel. When I made this title slide, I had no idea we were going to be having the electric grid problems that we're currently facing. I'm just glad that I'm able to be here taking part of this outstanding educational event congratulations, everyone. So this is kind of an overview of how we approach melasma as a referral-based center here in Houston. And I want to emphasize, as Dr. Kavar did, the role of standardized baseline photography, which is really critical. The baseline photographs that you take are the most important photographs because those are going to be the ones that the patients are always going to be referencing back to when they come in for subsequent treatments. So that's imperative that you have proper lighting, proper standardization, and that your staff is well educated on how paramount the role of the photography is during the initial consultation. Now, in addition, we'll perform ultraviolet photography as well as spectrocalorimetry, which I'll show shortly. And you want to just make sure that all the makeup is removed. I know that sounds obvious, but it's not uncommon that I walk into the room, especially for a new consultation, and I find that I'm removing makeup, which can be frustrating, especially after you've just taken your baseline photographs, which again, those are going to be what your patients are referring to every time they come back for subsequent visits. So really, really paramount that those are taken properly, the hair is pulled back, et cetera. Subsequently, we'll perform an exam and an extensive medical history regarding prior treatments, any procedures, as well as the responses. Exacerbating factors will be discussed, such as, especially here in Houston, the role of heat. We'll talk about outdoor exercise activities, maybe the role of hot yoga. Certainly we'll talk about the role of hormonal usage, as well as the role of outdoor activities, as mentioned. And then we'll go into the role of family history, as well as the possible vascular component that's been mentioned previously. And it's not uncommon for us to diagnose a subtle case of rosacea in these patients. And there seems to be some overlap, and we'll talk about that. We'll talk about the multifactorial role in terms of etiology, and we'll emphasize that to patients, as was mentioned so well by Dr. Kavar and Dr. Desai, that this is a chronic condition, and we're not providing a cure. I'll often educate patients on who's most commonly affected in terms of patchwork skin types 3 to 6, the genetic and racial predisposition for individuals of Asian, Latino, and African American descent. And then we'll talk about genetic predisposition, UV radiation, the role of visible light, blue light exposure, barrier abnormalities, hormonal sensitivities, as well as hormonal replacement therapy. And I think it's that educational component is so critical. And then as the consultation moves along, I think while you're in the photo room, it's a great time to educate the patients on what's listed on this slide here, and as some has previously been discussed in terms of the role of proper sunscreen and sun protection against both UV light, infrared light, and visible light from both the sun and artificial sources, and talking about the role that artificial light sources can play, including digital screens, light-emitting diode lighting, and high-energy visible or blue light therapy. And this is an algorithm that I commonly utilize to teach residents and fellows on my medical and cosmetic approach to treating melasma and the multimodality approach that we typically take, and really emphasizing the behavioral modifications that are of paramount importance to take by the patient before intervening with any in-office procedures. We'll talk about, as mentioned, the role of hormonal therapy. We'll talk about preventative measures such as various types of sunscreens that have been previously discussed, the role of polypodium, an oral dietary supplement that's taken from Central and South America. It's a firm that has gained interest in the management of melasma for its antioxidant and potential photoprotective properties. Our topical approach with various lighting agents has also improved greatly recently, and the majority of patients who are referred to our center have previously been on hydroquinone and have experienced some of the issues that have been discussed. And so we're commonly going towards other topicals, as was discussed, including 3% tranexamic acid is a real workhorse in our practice. For several reasons, we have found that it's very well tolerated for patients, and we certainly don't want to cause any further irritation. And we'll talk about, this is something that we'll talk to patients in terms of doing what they can do to maintain the skin with good moisturizers, especially when using a combination approach with topical retinoids or azelaic acid. So what's interesting is that the role of oral tranexamic acid is actually becoming also a more integral part of our practice, even though we're a major laser referral center, because of how successful we've been with it. So for patients with more advanced or recalcitrant melasma, we'll talk about the increasing use around the globe of oral tranexamic acid and our experience in that arena. And especially during the summer months, when we're less likely to utilize energy-based devices, typically I'll provide the patients with literature on some of the potential contraindications in terms of the proper hypercoagulable workup that needs to be performed and discussed in terms of prior history, and the potential risks that are very, very low, in my opinion, with proper screening. And so I'll give something for the patients to think about for a subsequent visit. So again, we've done all of this in the office at our initial consultation, and we still haven't discussed any energy-based procedure yet. And that's because, in my opinion, in my experience, it's important that all of these things are understood by the patient before moving forward with an energy-based device. So you want to provide proper education, you want to go through the baseline photographs, and you want the patients to demonstrate that they understand the importance of behavior modification, almost that they have to earn these office-based procedures before we'll perform the procedure, especially during the summer months. And we'll go through all the various office laser devices that we use commonly in our practice, but I just want to reemphasize the importance of proper patient selection and education and consultation before moving forward with the modalities that we're going to be discussing. We talked about the role of pre-treatment photography and a reproducible position and lighting. And then we're going to show some examples of ultraviolet photography, which can be utilized to detect subtle melasma. And certainly we'll talk about the role of spectrocalorimetry to detect any signs of telangiectasias within lesions of melasma, and to help educate patients on the role of underlying vascularity and how it ties into the treatment modalities that we may be recommending. So in this study by Dr. Negishi, she utilized ultraviolet photography to detect subtle epidermal melasma that was difficult to detect under normal light, and we utilized ultraviolet photography to enhance the appearance of epidermal pigmentation. And in this study, Dr. Negishi utilized UV photography to identify 63 cases that were not clinically diagnosed as melasma, and the concern here is that you could exacerbate melasma with aggressive treatment. And so even those patients who aren't necessarily referred into the practice for melasma. With proper photography, history, and education, it's not uncommon for us to detect subtle cases of melasma that can be important before we move forward with energy-based devices. And certainly you want to avoid any treatment of tan skin. So this is spectrocolorimetry, which has become an integral part of our approach for approaching patients with melasma. And you can see here in this retrospective analysis that we published in Laser and Surgery and Medicine, you can see the nice enhancement of vascularity and telangiectasias that correspond with the areas of enhanced pigmentation in this patient. And I'll talk a little bit about how we have subsequently utilized this to educate patients on the role of using vascular-specific devices to help us in reducing this underlying vascularity and ultimately, hopefully reducing the chance of recurrence. In this paper that we published here, we targeted the underlying vascularity with the 595 pulse dye laser in combination with the pigment-specific modality, and found that the parallel improvement, as shown here, in both the pigmentation and underlying telangiectatic erythema suggested a relationship between the underlying vasculature as well as the hyperpigmentation. You can see that spectrocolorimetry nicely detected the telangiectatic erythema corresponding to here the lesion of melasma at baseline. This was an interesting paper that was just published by Dr. Geronimus's group, looking at dynamic optical coherence tomography to demonstrate the effect of oral tranexamic acid on cutaneous blood vessels in melasma, where they found that both lesional melasma and normal skin showed a reduction in blood flow throughout the dermis with sustained use of oral tranexamic acid. However, the reduction was more substantial in the superficial dermis of the skin affected by melasma. This is a patient who presented to our practice with a 5 to 6 year history of melasma. She reported a history of exacerbation of the melasma by previous laser treatments. She underwent 3 IPL treatments without improvement, and we'll typically see a significant number of patients coming into our practice who have had their melasma exacerbated by IPL treatment. And my estimation is that a majority of these patients had a subtle case that was not detected, that was then exacerbated by too much thermal heat being delivered. And again, as mentioned previously in my talk, I'll have a long conversation with this patient about oral tranexamic acid first, before moving forward with laser therapy, because of the results that you can see here. This is a patient, here she is 4 months after oral tranexamic acid, after proper screening, and you can see a substantial improvement. She took the tranexamic acid orally, 250 milligrams twice daily, and you can see excellent improvement in combination with a topical retinoid and a good antioxidant regimen. All right, so here we are. Now we're finally going to get to talk about lasers, and this is from a chapter that we just published in Cosmetic and Dermatologic Surgery, giving an overview of the advances in laser devices to manage melasma, starting with picosecond lasers that work predominantly through photomechanical effects to cause fragmentation of pigment particles, allowing for minimal photothermal damage, which should decrease the risk of post-inflammatory hyperpigmentation and rebound melasma from the unwanted heating of skin. And in prior split-phase studies, picosecond lasers have demonstrated faster pigment clearance and greater improvement when compared to nanosecond technology. I've been very involved with non-ablative fractional resurfacing from the very beginning, and I'm happy to discuss my approach further during the Q&A. But just in terms of a brief overview, non-ablative fractional lasers create microscopic treatment zones which spare the surrounding tissue, allow for shorter recovery, fewer side effects. And in this case, you can control the density, which you want to be low, and the energy, which you want to be low, when utilizing these modalities to treat melasma, with the ultimate goal in reducing the number of normal and enlarged melanocytes and decreasing melanin in the surrounding keratinocytes. Certainly, Dr. Kavar is a world expert on low fluence 1064 Q-switched ND YAG laser, so I won't discuss that. And then she also mentioned the role of pulse dye laser as a role to target the underlying vascularity, which we can discuss further during some of the cases to prevent frequent relapses. But ultimately, as has been previously discussed, this is not a cure. Multiple gentle treatments are required. Less is more, and we always lengthen the treatment intervals to minimize the chance of post-inflammatory changes. So in conclusion, the most critical component of the laser treatment of melasma is ensuring safety for patients because of the potential for rebound, hyperpigmentation, or exacerbation of the melasma. The way to do this is to under-promise, over-deliver, emphasizing the chronicity of the disease and that you're not providing a cure, and discussing the fact that a combination approach is required. You want to create realistic expectations, show a variety of before and afters of different skin types, and baseline photographs are critical, utilizing ultraviolet photography as well as spectrocalorimetry. And I look forward to going through some of our cases at the end. Thank you.
Thank you, Paul. And we definitely have a great variety of cases to talk about that will hopefully demonstrate all of these things. Kanika has some questions before we get to Dr. Sarkar's talk. So Kanika, are you going to bring some of those up real quick? Thank you.
Thank you. Thank you, Dr. Munavali. We've got quite a few questions on many of these things. It's a great and interesting talk. Questions about microneedling. What does the panel think about microneedling in melasma and microneedling specific agents? Are there favorite agents, and can you elaborate?
Yeah, so microneedling was mentioned by the last two speakers, and I think more in the context of potentially of topical drug delivery. Microneedling itself obviously has no energy that's delivered with it unless it's radio frequency, but we wouldn't necessarily use that in this situation. So can I get the panelists, anybody who uses microneedling routinely for topical drug delivery, to comment on this, please?
Yeah, so we discussed, Dr. Kavari, we discussed the role of microdermabrasion. We aren't using microneedling in our practice for the treatment of melasma. Are you, Dr. Kavari?
No, I am not. I don't see a role for microneedling in these patients. Again, I was discussing microdermabrasion for exfoliating the stratum corneum.
Okay, Dr. Desai, do you use microneedling at all in I know you use it sometimes in combination for dark under eye circles. Can you comment on that, please?
Yeah, so I use microneedling extensively in my skin of color patients, particularly for post-inflammatory hyperpigmentation associated with post-acne scars. And I have had patients who have had overlap with PAH and melasma, and I found it somewhat effective. We're actually doing a study as we speak on microneedling and subsequent topical tranexamic acid mesotherapy. So the study, it's shallow depth microneedling. We're going really shallow. We have about 16 patients enrolled in the study. Its data has not been published, so I can't say much about it yet because it's too early. But we are doing a study to kind of see if mesotherapy component can work well. And I actually learned that trick from some of my colleagues in India from working with them in the pigment world. So the short answer is I've done it. I don't do it a lot, and we're doing more studies on it in particular.
Okay, thank you. Kanika, do you want to take one more question, or should we move on?
Yeah, let's take one more question, and that involves how do you make melasma worse? There are questions about how microdermabrasion would appear to possibly make melasma worse, lasers. Can the panel comment on how some of these modalities can both help and also possibly worsen melasma?
I'm happy to take it. I'm sorry.
Go ahead. Go ahead, Ariel.
Sure. So I think the issue is that patients with melasma are very sensitive to inflammation. And we see this when they get irritated from their topical skincare routine and they actually have darkening of their melasma. Pretty much every laser that we have in our armamentarium has been studied for melasma, whether it's ablative lasers or high energy pigment lasers using typical tattoo settings or settings for solar lentigines. And all of those high energy settings result in exacerbation of melasma. And that's, again, I believe, from the inflammation as a result of thermal injury. We know that inflammation is a big stimulus for pigment incontinence, and I think melasma patients have a much lower threshold for that. I've never seen an exacerbation of melasma from a microdermabrasion. I consider that a very gentle treatment, and in my experience, there's less risk with a gentle physical exfoliative procedure than using a chemical peel, where you may have deeper penetration depending on the skin and risk inflammation. So I think that's a very safe procedure.
Okay, thank you. We're going to continue with our last speaker of the evening before we get to cases. And again, very honored to have Dr. Rashmi Sarkar join us from New Delhi, and she's going to talk about medical management of melasma. So thank you, Dr. Sarkar.
So good morning, everyone, and thanks so much, Dr. Munavali, for that lovely introduction. I'm very glad to be here amongst all these international panelists talking about melasma. We've already heard a lot about energy-based devices and other modalities of treatment for melasma. I'm going to confine my discussion more to medical management. And believe me, medical management does work, for melasma, because it's first line. So looking at the therapeutic options and these little boxes, topical sunscreens remain the mainstay. So a broad spectrum sunscreen with an SPF of at least 30, that is what works in our practice, with inorganic sunscreens, that is titanium dioxide or zinc oxide or iron oxide, which is coming up, is important. And we ask the patient to reapply every 3 hours from about 8 to 4 p.m. In the topical hyperpigmenting agents, as very nicely said by Dr. Desai and Dr. Ariel, hydroquinone, the phenolic agent, does remain right on the top. We don't have anything which is as good as hydroquinone, although the search is always on. And hydroquinone and the triple combination therapy containing hydroquinone and fluocinolone acetonide with tretinoin, no other steroid, is important. We have to remember that only fluocinolone acetonide is the one which should be used, 0.1%. The other agent, as rightly pointed out, is histamine, which is probably showing some amount of headway. Well, this would be first line of management, triple combination therapy or hydroquinone. In the non-phenolic agents, we have in our armamentarium tretinoin or any of the other retinoids. I'd like to say here, even adapalene works very well topically, because dark skin like ours gets very irritated sometimes with tretinoin. Azelaic acid, which has a good level of evidence, kojic acid, vitamin C, arbutin, glycolic acid 10%. This is another very good agent, works quite well, quite soothing for melasma. And topical corticosteroid is only for chemical peel patients sometimes. So this is something that we have to look into. Normally, what we use for maintenance after about 6 to 8 weeks of triple combination therapy is a cocktail of these products like kojic acid, vitamin C, glycolic acid 10%, or even arbutin. Second line therapy for us remains always chemical peels, and for patients who are not naive patients of melasma or have already been treated a lot, chemical peels could be a very good option. So these are some of the mono peels, conventional peels, which have a good level of evidence, like glycolic acid peel, salicylic acid peel, again in combination with mantelic acid peel, or lactic acid peel. These are things which can be used. Tretinoin 1%, Gessner solution, lactic acid, which is a softer peel. You can use it for maintenance over a long period of time. And when I say phenol, this is modified phenol peels, not the ones which have, croton added to it, but phenol in dark skin modified with maybe 10 to 15% of TCA and other combinations works well for a deeper type of melasma sometimes. Well, lasers, I'm not going to talk so much here. It's already been discussed. But yes, there is also emphasis now on microneedling and other physical therapies like platelet-rich plasma, which is coming up. And last but not the least, oral agents like tranexamic acid. So let's have a look at the evidence-based strategies for maintenance and prevention of melasma. As I've already mentioned, sunscreens are one of the mainstay of treatment. You have to learn how to use them well, and 2 milligrams, that is per centimeter square. And education of the patients is very important. And it has a good level of evidence, 2 to 4 in randomized controlled trials. The other thing, as I said, which tops the list is hydroquinone 4%, which heads the list in evidence, good level of evidence, and followed by 2%, which is considered to be more OTC, I know, in the US, but yes, 2% is used quite a bit in India. Others which work well are azelaic acid, kojic acid, and vitamin C. So I would like to say that use these for maintenance once we make a headway with hydroquinone or with triple combination therapy. So this is a little cycle that I'd like you to have a look at, which explains that what works strongly in melasma and skin lightening agent, and what works more as a agent which is not that strong but good for maintenance. So this is the cycle of melanin production or the melanocyte pigment cells. So right at the top we have the glycosylation which occurs, that is of tyrosinase, and those which inhibit the tyrosinase glycosylation are glucosamine and N-acetyl glucosamine. These are there in a lot of OTC products and in a lot of cocktail skin lightening agents. These are lighter agents and are something that you can really use for maintenance therapy. Next is the activated tyrosinase, which you see in the middle. And this converts the tyrosine to the melanin, which is packaged again in the melanosomes. These are the tyrosinase inhibitors, which are actually some of the most powerful treatment in melasma. That is hydroquinone. There is kojic acid, arbutin, ascorbic acid, pretty much are very important armamentarium. And tyrosinase copper chelation, that is ellagic acid, and so many other chelators that we have. These are little stronger than the other agents. Next, once the melanin is formed, this is packaged into melanosomes, and then it is transferred to the keratinocytes. So what happens here is, which are the agents which prevent this transfer? And that is agents like niacinamide. Now, niacinamide, a lighter agent, is again a pretty good agent which works well for melasma and not as powerful as hydroquinone, but excellent for maintaining, that is the therapy, maintaining the lightness of melasma, because remember that melasma is a lifelong condition like diabetes, so has to be treated. Next, of course, is the last part, transcription of the tyrosinase gene. So the downregulation of tyrosinase, these are agents like retinoids, tretinoin, and we have good results even with adapalene cream. And anti-inflammatory agents like hydrocortisone and glycerinic acid, these have to be used very careful. Remember that there are steroid-related side effects. And antioxidants, there's more and more evidence coming into antioxidants working on the oxidative stress, that is, which works in melasma, that is vitamin C, vitamin E, and sulfhydryl compounds. So overall, we have many agents, the stronger agents like tyrosinase inhibitors, and the maintenance agents, which are a little lighter. So this is what was made by the Pigmentary Disorders Society, which we have in India, which has Indians as well as international experts. And we had the SPF or the South Asian Pigmentary Forum. So this is our algorithm that we made from our various roundtable meetings. If you want to read more of this, this has been published in the Indian Journal of Dermatology November-December issue 2017, and it's available free online. Assess a patient of melasma clinically and with Wood's lamp wherever possible. Divide into epidermal, dermal, and mixed. And it's the epidermal that responds well as the mixed. Treat any triggering medical factor, as rightly pointed out by Dr. Desai. Thyroid abnormalities are something we need to look into. Photoprotection with a broad spectrum sunscreen with minimum PA 3+, with inorganic sunscreens, titanium dioxide, zinc oxide, or iron oxide works. As I said, our first line remains medical management, and that is topicals. So if you have mild melasma, when I talk about mild melasma, this is with the MASI or the Melasma Area Severity Index, maybe say 8 or less. Start with mono agents like hydroquinone. You could give this for about 6 weeks or 8 weeks and then maintain with kojic acid, azelaic acid, arbutin, tretinoin, ascorbic acid, or combinations of any of these products. For moderate to severe melasma, if there is no contraindication, triple combination therapy with hydroquinone 4%. If this is not tolerated, you have sensitive skin or winter months, dual combination with hydroquinone and tretinoin or any of the other dual combinations can be used. And review all kinds of topical therapy at 4, 8, and 12 weeks. I would say I would not like to go at a time beyond 8 weeks. And then either we make it twice a week or we go over to the other agents, the non-hydroquinone products, which you see on the left, the maintenance agents like kojic acid, 10% glycolic acid, arbutin, and so on. Second line therapy for us remains chemical peels again, and 35% glycolic acid is versatile or combinations of these. This is where oral agents can be added with topicals or with peels if you want to do that. Again, third line for us, in dark skin, we are skeptical. Lasers and lights, but they can be used carefully, again, with or without oral agents or topical. So this is something that we do, and we have to look for side effects after every 4 weeks, whether it is ochronosis or side effects of hydroquinone or with steroid-induced side effects that we see a lot, which can either be telangiectasia or thinning of the skin or striae. So when we look at that, we have to decrease the treatment and switch over to the other agent. So here's where I talk about oral tranexamic acid, which has made a lot of difference to our patients, and especially patients of melasma who are not naive. As we know, it has a multiple mechanism of action, but plasmin and plasminogen pathway is something that is important and inhibits it. And it disrupts the melanocyte-keratinocyte interaction, reduces level of beta-FGF, and decreases the activity of mast cells. The dose is up to 500 milligrams. Usually, we like to give it in 2 divided doses. The effect starts to come in 4 to 6 weeks, and it has a good level of evidence, 1 to 4. Side effects are, usually this is quite well tolerated, but there are GI disturbances, reversible hypomenorrhea. Rare are, of course, the deep vein thrombosis, myocardial infarction, pulmonary embolism, a good history and a family history, and also that of recurrent abortions in women. Relapse rate is about 9 to 27%. So as I said, doing a coagulation profile is important. So prothrombin time, APTT, and clotting profile is important. And we start at 250 milligrams twice a day or 500 milligram OT give up to 3 to 6 months. And it can be combined with proanthocyanidine, vitamin B, C, E, and topicals again. Effect occurs at 8 to 12 weeks, and we must give for 3 months before declaring ineffective. So there are some contraindications like coagulopathy, hypersensitivity, cardiovascular disease, stroke, and patients on anticoagulant medications. I leave you last with 2 things where there's a lot of hype, myth or reality, that is glutathione, and the other is PRP or platelet-rich plasma. Now, talking about glutathione, at best today, it is a good skin lightening agent, but for melasma, there isn't any proper evidence. And this, of course, has a direct binding with the copper-containing active sites, inhibits tyrosinase, and is an antioxidant. Studies have found that it reduces melanin index in both sun-exposed and non-exposed skin, and 500 milligrams can be given for 4 to 8 weeks, and mesotherapy with vitamin C has been given in case series, but IV glutathione is a very big no-no. Side effects are Stevens-Johnson syndrome, toxic epidermal necrolysis, thyroid dysfunction, and lightening of hair, and peptic ulcer. Regarding platelet-rich plasma, this is something that is gathering evidence now, and we've had good results combining with hydroquinone. It has currently almost level 2 evidence. It again works. The TGF-beta-1 released from alpha granules in the platelets causes a significant inhibition of melanin synthesis through delayed extracellular signal-related kinase activation. It also causes an increase in the skin volume. This is the PDGF in the PRP. So it gives a result. It makes it look as if there is an increase in skin volume and lightening of melasma. So this has been shown in small studies that it decreases the MASI and the modified MASI in about 3 months. So what we typically give is 3 to 6 sessions at 2 to 4 weeks interval as mesotherapy, or it can be combined with microneedling. So platelet-rich plasma, a lighter treatment, but something that you can look forward to in the future, and you could combine it with even hydroquinone. So what I'd like to leave you is with the key messages. Definitely, medical management of melasma remains first line of treatment, but combination treatment with physical modalities like peels and lasers definitely optimizes outcomes. And as rightly said, we have to be careful even with the laser toning that is used a lot in our country. Photoprotection remains an important part of treatment, no matter whether you use your medical treatment or energy devices. Counseling is the cornerstone, and we have to tell the patients that this is a lifelong disease. Thank you so much for your patient hearing, and I turn it over to Dr. Munawali again. Thank you.
Okay, thank you, Dr. Sarkar. Wonderful, wonderful lectures by everybody. That was amazing. And I hope you can appreciate the way that the lectures blended both medical and the laser and device treatments. That was by design. I know we have a wide audience, but in this particular disorder, mastering both of those is key to being able to treat this disorder. Kanika, I'm going to ask I know there are a couple questions on topical agents before we get to the cases, since that's pretty relevant right now. Kanika, did you have anything specifically? I know there's potentially questions about tranexamic acid topically, or anything like that, or polyploidimus.
Definitely. Lots of questions about tranexamic acid, length of duration of oral treatment, as well as do you microneedle tranexamic acid, and do you have specific preferences on topical tranexamic acid? Also questions as relates to that are, is there a specific panel of labs that you check in particular?
So in summary, I guess, what labs are checked before putting somebody on oral TA? What's the duration of oral TA? Those all were mentioned, but I think Dr. Sarkar could mention them again. And then in terms of microneedling with topical tranexamic acid. So, Dr. Sarkar?
Yeah, what was the question, Dr. Munawali?
There was just 2 questions to reiterate what you said about the labs that you may use, the laboratory tests before starting oral TA, and then yes, how do you manage the duration of oral TA with the seasons, for example? Do you time it to be on during the summer and off during the winter? How do you manage that?
Okay, you mean with the topicals?
No, ma'am, with the oral.
Okay. So first of all, when we are contemplating, giving tranexamic acid, a coagulogram is important. And I had given a checklist regarding thromboembolism and all those things. So I've already mentioned prothrombin time, do an entire coagulogram, that would be important. Regarding duration, as I said, it's about at least 3 months before you say that it's not really working. And in my practice, we combine it a lot with topical treatment. We don't really sometimes give tranexamic acid alone. So some kind of, topical treatment is always given. 6 months is a duration we can go up to, although people have given up to 1 year. I like typically giving it to 6 months and then rotating. Regarding, seasonal variation, we've not seen too much of a problem, but in case you feel that there is a lot of dryness and, tightening of the skin when you're combining with any kind of topicals, I think moisturization is the key. Always good, to combine it with agents, moisturizers like, and agents like niacinamide, maybe even, skin creams containing, aloe and other things. So these are some things that can be done with the, if you feel that seasonally there is more of a dryness of the skin in winters.
Kelly, I would just add that, we are using, this is where I think lasers are so great, is we're using the lasers to help lessen the chance of recurrence for patients that we treat with, say, oral tranexamic acid, especially during the summer months. So that's kind of the way I've been positioning it in my practice, that we're utilizing these energy-based devices to lessen the chance, some of those recurrence numbers that were mentioned, utilizing some of these office-based procedures. I also want to just add that we also will ask patients about a smoking history. We won't prescribe it to patients who have a smoking history. And during this pandemic that we currently find ourselves facing, we will also talk to patients about that if they do contract COVID, given the hypercoagulability associated with COVID, that they need to discontinue the tranexamic acid as well. And I will mention that we have patients sign a consent outlining all, after going through the questionnaire, we'll have a patient sign a consent that goes through all the risks that have been discussed.
Okay, Simo, do you draw patient labs, and what is your feelings on oral contraception with TA?
So oral contraception is a no-no for me in oral tranexamic acid. I'll do topical, but I don't make any exceptions to that. This is something that's off-label, and I'm pretty gutsy at doing off-label stuff, but OCPs or someone who's a smoker or someone who's had a history of spontaneous miscarriages or things of that nature, they don't go on it. But your typical male or female, and by the way, remember, melasma happens in men as well. We tend to kind of bottleneck everyone thinking that melasma happens only in women, but remember, men get melasma too. I have a huge cohort of male patients who get melasma on the face and also on the dorsal forearms bilaterally. The most common extrafacial site for melasma is a clinical pearl for those tuning in. In terms of labs, I will tell you, I have waxed and waned on that. There was a time where I was doing no labs except getting a detailed history and documenting that on my patients. And that was mainly out of the work in Singapore with Professor Chi Go's group, who published the largest cohort of patients in the Blue Journal with oral tranexamic acid, and they did not do any pre-screening labs. I will tell you that recently in the past year, I do get a baseline CBC and those factors that Dr. Sarkar mentioned in her talk. I think that's reasonable. Again, the question with the labs becomes, what is the risk? What is the benefit for the patient? I do agree with the consent form and documenting, as Paul said, and we do that as well. And my final comment on tranexamic acid is, in general, when tranexamic acid works for someone with melasma, it tends to work pretty quickly. This is not the type of oral drug that I'm going to say you're going to be on for a year and let's see how it goes for 9 months or 12 months. When it works, it usually works in the first 12 weeks, in my opinion. I've seen results in the first month, to be frank, on oral TA, and it works pretty fast. And that's nice, because this is not the type of thing I'm going to say, hey, let's just wait and see how it pans out in 9 months from now. So if it works fast. If it doesn't work in 3 months, I say stop it. It's not going to work anyway. And the BID dosing is important. I always get asked, what about some titrating down to Q-day and tapering people off? And that sounds good. It makes us feel better that we're maybe making these people less prone to side effects with once daily dosing. I've tried it. Just doesn't work that well because the half-life of tranexamic acid is only about 7 hours. So that's why the BID dosing is really more effective.
Okay. Ariel, there was a question about maybe a little bit more clarification on bimatoprost for patients who might develop the guttate hypomelanosis. Could you expand on that a little bit, please? You might be muted again, Ariel. I'm not sure.
Sorry. Bimatoprost is a glaucoma medicine. It's a prostaglandin analog, and it turned out when patients were using it, it grew eyelash hair. So this is marketed as Latisse for growing eyelashes, but it's the same as the medical Bimatoprost for glaucoma. In addition to growing hair, it also increases melanin production. And so procedure that we use for repigmenting depigmented or hypopigmented skin is using a low density, low energy fractional ablative CO2 laser to drill little holes. And then we apply the Bimatoprost solution directly to the skin. And we put some ice compresses on and let that sit for about 10 minutes. And then actually apply topical corticosteroid in suspension right over that. And we do this for the gut to aid hypomelanosis, but also for other things like white scars.
Okay, thank you. There are a lot of questions about chemical peels. So for the faculty that want to answer this, what is your favorite peel and why? I'll start with, let's start with Dr. Sarkar.
Yeah. So, Dr. Munavali, chemical peels are a favorite, and I'd like to say that I do consider glycolic acid peels 35% or in combinations to be one of the most versatile peels in my practice. Having said that, combinations with mandelic acid peels, like whether it's the salicylic mandelic acid peel and other combinations also work well. So I would like to say glycolic acid peels and the salicylic mandelic peels, which remain my favorite.
And I think those are all available in the U.S. I know there's a mandelic peel now available in the U.S. And I know we use between, we will use 70% glycolic, but not for melasma necessarily. Simo, any comments on that?
We're using 35%.
Yeah, I would echo and agree with Rashmi's comments. I do think that if you look at all the literature and do your own meta-analysis, glycolic acid has the best data in melasma, but I have really switched a lot of my peels to sequential combination peeling, and I really like combining salicylic and mandelic. I think you get a nice synergy between the alpha and beta hydroxy acid. And also,
can you mention the brand name of that, Simo? Can you mention the brand name of that?
I use the Glytone one, and I like the Glytone peels. I don't have any financial interest with them except that we buy them. But I like the Glytone peels. But keep in mind, chemical peels if you want to get those acids at a really low price and you want to get a multi-use vial, you can go to your compounding pharmacy. There's a compounding pharmacy in my building here in Dallas. They'll make us a 60 ml vial of 30% sal acid for about $16. Those are multi-use vials. So, I mean, if you're on a budget in your practice, you're starting out, you want to just kind of dabble with it, you don't want to charge your first few patients, you don't have to go fancy. The reason I like the Glytone ones is they're kind of no muss, no fuss. They're easy to use. They're single applicators. My estheticians can do it. I can do it. And I like that. So that's how I like those.
Okay. And those glycolics have to be neutralized, right? The glycolic peel?
Yes, it has to be, it has to be neutralized. Okay. So we use either cold water or we use cold water sponges once we get, the redness. In dark skin like ours, we often don't see the redness. So burning sensation would again be another thing, which you should terminate the peel with either cold water or cold water sponges. You have to neutralize it.
Anybody on the panel use TCA peeling? That was one question. I didn't think so.
I use TCA. Oh, actually, Gilly, I was going to say I do use TCA, but keep in mind I do use TCA. I don't use it ever on the first, second, or third chemical peel session. If I'm going to use it, it's going to be on like session 4 or 5 once I've already tried the other acids. And keep in mind that until you get to about a TCA concentration of about 18%, it's not technically medium depth. So there's been a good amount of studies out of the Middle East. Our colleagues have used 10 and 15% TCA. That's still technically superficial depth. I think we're all trained to think when you hear TCA, that means medium depth, but it's only medium depth at a certain concentration and higher. So yes, TCA can be used. Peter Rowland in San Diego uses a lot of that. I learned that from him, where you can do sequential peeling, use salicylic acid for sessions 1, 2, and 3, and then bump up to TCA if the patient's not budging. So yeah, it is an option.
Okay. Okay, there are a lot of questions about proprietary.
Yeah, sorry.
I'm sorry.
One thing I'd like to say that when you're using it on dark skin patient, look only for flecks. It may be better not to look for a full, pseudo frost, but better to look for flecks because there can be a lot of, post-inflammatory pigmentation.
Okay. We will transition to our first case and then go back maybe to some more questions. A lot of questions about proprietary chemical peels, and I would just say just know the ingredients. That's the most important thing in these peels. So many different names. Paul, this is your case. Do you want to go with this one, please?
Thank you. This is a patient who presented with a long-standing history of melasma and poikiloderma of the lower face and the neck. And she had received numerous treatments actually in New York with both the picosecond Alex as well as a Q1064 Q-switched into YAG as well as chemical peels with still some recalcitrance as shown. So we talked about the role of the vascular component, and we intervened with 3 pulse dye laser treatments sessions, and then subsequently she received 10 treatment sessions utilizing the 1064 nanometer picosecond laser. Typically we're doing these at about 6 to 8 week intervals, and you can see the excellent improvement here of both her the dyschromia and vascularity on her lower face and neck. In terms of treatment settings, we utilize the 595 V-beam laser with the 10 millimeter spot. We utilize 6 to 10 milliseconds of pulse duration with 5.5 to 6 joules per centimeter squared and the 30-30 on the cryogen spray. And then with the peak away, we utilize the 1064 6 millimeter spot, and we used 1.1 to 1.2 joules per centimeter squared in terms of the associated fluence with that device.
Yeah, that's an excellent result. Very hard to achieve. Excellent result. And our next case is also Dr. Friedman.
So this is a patient with Fitzpatrick skin type 3 who presented with melasma. She was educated on the importance of proper skin care, sun protection, sun avoidance. She was put on topical skin brighteners that included 3% tranexamic acid, vitamin C, as well as a HelioCare dietary supplement. She was subsequently treated 2 months later. You can already see the improvement in the middle photograph. She was then decided that she had earned the right to undergo energy-based therapy. So we intervened with the V-beam laser for the underlying vascularity, followed by the low energy, low density 1927, as well as 1550 non-ablative fractional resurfacing. And you can see the nice improvement shown 2 months after one treatment session. We certainly applied air cooling and ice packs during the treatment to reduce discomfort and inflammation. Topical steroids were applied twice daily following the treatment times 2 days to decrease inflammation and minimizing the risk of associated PIH. And I will just caution that recurrence and rebound may be an issue, so long-term follow-up in proper settings and proper patient education are critical.
Okay, thank you. So that brings this patient. So Dr. Kavar, this patient is in your office in New York. What are some initial thoughts on this patient? I saw this patient last week and I referred her to you in New York. So what are you thinking with this one?
Well, certainly my first reaction would be just to find out what she's done before. Has she had a good topical regimen that she's failed or not? And but what I would do is I would talk to her about her triggers, talk to her about her responses to previous therapy, hormone status, medications, all the other things we discussed, and then really try and find out whether she was compliant with a topical regimen or not. And I would put her on a topical regimen, having imaged her, bring her back in around 6 weeks, see how she's doing. And at that point, if there's no substantial change, then we would talk about laser options. This is assuming she had a real trial of topical therapy before. And since, at least clinically, she has both dramatic pigmentation as well as erythema, I would not hesitate to combine a picosecond Nd:YAG and pulse dye laser together in the first treatment session.
Okay. Thank you. Any other panelists? Any other comments on this particular patient?
It just looks to me that she's also perhaps experiencing, she might be doing something that's causing some irritation to her skin. So this is somebody, as Dr. Kavar mentioned, where you'd want to manage medically before considering any energy-based or office-based procedure. And I think a combination treatment with a topical steroid might be useful as well.
Yeah, there is a lot of erythema actually. It does seem it's more red than anything else. So there's a bit of an inflammation. So I think even some amount of moisturization, that is also important. Sometimes it helps in reducing the irritation.
Okay. So my next case is this patient. And I just put this patient in to highlight, it's kind of hard to tell, but this was a mid-30s-year-old female who presented with this melasma, and she's originally from Arizona and then moved to North Carolina. And I thought this was a good example of what Seema and Paul and Ariel were talking about with regards to vascular. It's a subtle vascular thing, but she was actually enrolled in a study we did, was a split-based study where we treated one side with the Q-switched Nd:YAG plus pulse dye, and the other side with just Q-switched Nd:YAG. And I don't know if anybody can tell the difference between the two, but we did measurements with the mexameter and erythema meter just to see, just to compare the two sides. And it actually turned out on this patient, the left side was both, and her right side was just the Nd:YAG Q-switched for toning. So what we found consistently, we did about 12 to 14 patients in the study, is both the erythema, which predictably with PDL, but also the mexameter for pigment, both were statistically significant improvement on the combination side. So I thought that would be interesting to show in lieu of you're not seeing a lot of discrete vascularity here, just some mild, it's a little harder to tell, but there was some. So this next patient I've been following, and before I tell you what I did, Seema, how would you approach this patient? On the left is when she came into your office, and this is an unusual presentation for you to see.
Yeah, I think for me, the first thing when I see this case is to even ask myself, is this truly melasma? I think we have to be careful to not box ourselves into thinking that every form of facial hypermelanosis is melasma. Keep in mind that one of the most common places for lichen planus pigmentosis is the face. That tends to be more preauricular and lateral temples. Facial acanthosis nigricans, lateral part of the cheeks. Some sort of PIH from some trauma on the skin is certainly something that I would probably think about in this person. So that would be my first comment. I think it probably is melasma if you look specifically around the orbital rim and the zygoma. You can see that the orbital cavity is pretty spared, and she's got the pigmentation sort of tracking along in a very sort of guttate kind of coalescing patch area. So it probably is melasma. So first, confirm the diagnosis. Someone like this, if they're not responding to therapy, I wouldn't hesitate to even do a small 2mm punch biopsy of the densely pigmented area if you absolutely had to, if they weren't responding to therapy. Find out how deep that pigment really is. If it's way down in the reticular dermis, you know that topicals and peels probably aren't going to get there. And this person certainly needs a combination therapeutic approach. Mm-hmm. I would probably start this person on one of my higher compounds, which I do is a 6% hydroquinone, a 0.1% dexamethasone, and a 0.025% retinoic acid. That's my sort of go-to for someone who's got really dense pigment. I do use dermoscopy, and then again, see how they're doing and follow with combination modalities. And this person's probably going to be someone who's going to definitely end up with a physical modality like a peel or a laser. Yeah,
that's exactly what I did. I was questioning the diagnosis. I mean, I think, can you make the comment that typically the melasma doesn't encroach into orbital rim?
Correct.
This
yes.
one is a little bit trailing in the eyelid, so it was kind of confusing.
Yep.
And it was unilateral, which was interesting on the non-sun, on the non-driver side. So it was confusing to me. We did not do any diagnostic biopsy work because she didn't want that. So I started what you did. I started her on a triple, but I used 12% hydroquinone, vitamin C, kojic acid, 12% with no retinoid, twice a day. And then we started laser toning about 3 or 4 weeks into the regimen. So now here she is, two treatments of picosecond with the picosecond 8 millimeter spot, 0.6 to 0.8 joules, and I typically use 3 to 5 hertz until I get a little bit of mild erythema. And I was actually pleased to see her on her way to resolving, and I'm still seeing her. But that's the exact reason I put that in there, and you were in my head. You knew exactly what I was thinking, so thank you. Here's another tricky patient, and Dr. Sarkar, what do you think about this patient? This is before any treatment at all.
So once again, if I look carefully at the patient, very fair-skinned patient, and no treatment has been given, but again, there is a little bit of an element of erythema. So it would be important to, take a good history. Does the patient have sensitive skin? That is another thing that you have to ask the patient, does the patient react to cosmetics very easily? Because I know that the role of cosmetics in melasma is poorly delineated. But yes, it can be there, and maybe, there can be a photosensitizing effect. Having said that, this is a patient that would need sunscreens and a good, one with inorganic sunscreens in it, and maybe with something that is protective from visible light, like iron oxide. So iron oxide or something with titanium dioxide or zinc oxide, something that I would prescribe to her. She would need, to start, we could start her off with, triple combination therapy once we've ruled out other things like thyroid abnormalities, oral contraceptives or anything else. And I'd like to also combine it, with some amount of moisturization. So initially I would go for triple combination therapy, maybe for 8 weeks, and then go slow, maybe make it twice a week. And my favorite second maintenance therapy is always a cocktail which is of kojic acid, vitamin C, arbutin, or some of these agents. So that is my maintenance therapy. Either I do that or with 10% glycolic acid. So first, triple combination therapy, then maintenance therapy with a non-hydroquinone agent for another 4 to 8 weeks.
Yeah, we actually did the same. We started her on a triple. Paul, do you have any comments on this one? It's a tough one. There's multiple things going on here.
Yeah, no, it's I would focus on the vascularity for sure. She's it's interesting is it's not the distribution obviously looks like it's more consistent with some sort of perhaps prior procedures. She also has some associated hypopigmentation. She looks a bit inflamed, but I would focus on reducing inflammation. I think she would do well with topical 3% tranexamic acid. And perhaps this is somebody that I might even consider topical oxymetazoline for the vasoconstrictive effect. But again, focusing, as was mentioned, on whatever we can do in terms of maintaining her epidermal barrier, good moisturization. And so this is somebody I'd probably see back after a couple of weeks just to make sure she's tolerating the regimen. And then I'd follow her very closely before intervening, but certainly with pulse dye laser would work wonders for her.
Yeah, this is a tough one. Ariel, would you do IPL on this patient at all?
No, I tend not to use IPL in melasma patients. I would go to V-beam, pulse dye laser, as my first line treatment. together with topicals, as Dr. Friedman mentioned.
Mm-hmm. Yeah, and that's exactly what we did. Subtle changes after just, I think it was 3 treatments, is lower energies. You can see a reduction in the erythema. I agree, and then Paul picked it up that she is actually a picker as well. And so you can see she has some little acneiform papules that she was beginning to form, and she would go after those. So we had to address some of those behavioral issues with her as well. And I ended up recommending she get started on an SSRI to help with that because she was sort of unaware she was doing it. But you can see some improvement with the pulse dye laser as well as the triple therapy. But this is a tough one. This brings in a lot of different, a lot of different issues. The next case, I'm going to let, this is Dr. Sarkar's case. So I'll let her talk about this one.
Yeah, so this was a 20-year-old female. You can see dark-skinned, patient with hyperpigmented patches on bilateral skin. This is very obviously melasma since 2 years after delivery. So when this patient came to us, definitely my line of management, because you know that here, this happened after pregnancy. So sunscreens, broad spectrum, as I said again, with inorganic sunscreens. It's very important to have that with either titanium dioxide or with zinc oxide. Triple combination therapy was something that I started giving her for about 8 weeks and clinically assess the patient. At every level, you have to look whether there's any ochronosis, but more importantly, steroid-induced side effects. Sometimes you can see that clinically or even with dermoscopy. Dermoscopy also helps sometimes in picking up, a bit of telangiectasia, which is there, or even early, ochronosis. If you see an encroachment on the hair follicular areas of worm-like structures. After about 8 weeks, that's what I do. I made it twice a week, the triple combination therapy, and alternated with non-hydroquinone agents like topical vitamin C, arbutin, kojic acid, and other cocktails. Niacinamide is again something that is pretty good if you have to give it. And I believe it's there in the United States as well. This works quite well. I typically go in for rotation therapy, and that is what I did in this patient, that I put the patient on non-hydroquinone agents, and I may revisit triple combination therapy again after a couple of months. But the patient was well maintained on both triple combination and non-hydroquinone therapy. And that's what I did, rotation therapy, along with sunscreens.
Okay, thank you. And
the other thing is, of course, moisturizers.
I'm sorry, go ahead.
So sorry, I'm done. I just said moisturizers.
Okay. I was just going to move on to your second case here. You could talk about this one. So this is a
35-year-old female who presented with, again, melasma. You can see it looks like melasma, but it's much darker. On bilateral cheeks and nose since 2 years. She wanted to get it treated, but this is a case where you have to be careful. You have to take a good history because she's likely to have been treated quite a bit from outside. She's probably not a naive patient. And there is a likely diagnosis of ochronosis with melasma. So you have to look for that, because when you see that it is much darker in some areas, as well as, there is a little raised or a pebbly appearance, that is when you think of ochronosis. And this can be confirmed, of course, with the dermoscopy. As I said, once you see the worm-like structures and encroachment of the follicular area, that's when you think that you have something like ochronosis. So you have to be careful. I just put her off everything else, and there was just sunscreens and a good amount of moisturizers that I did. Initially bland ones, like maybe white soft, petrolatum jelly. And then later on something which contains a lot of ceramides, because I think that gives a good amount of, repair. Ceramides or something that contains squalene and other products, that is something that I do for some time, about 2 weeks layoff period. And after 2 weeks, I put her back on 9 non-hydroquinone agents, softer agents, maybe, kojic acid, arbutin, vitamin C, and so on, and chemical peels. Initially 35% glycolic acid peels. In this patient, I had some phytic acid combination peels, that also has an antioxidant action. And I did it for about 6 peels each. That is something that I do. The other thing that could have worked is also lactic acid peels, which are softer before you go on to a more aggressive peel. I also added antioxidants to the treatment. So usually these are a combination of antioxidants that we get in India. And it takes a long time before this gets resolved, but a lot of hand-holding and counseling went, in telling the patient that eventually there will be a lightening of the pigmentation.
Thank you. Yeah, in the remaining 5 minutes that we have, Dr. Kovar has a couple cases that I wanted her to get to. So Ariel, can you talk about this case,
Sure.
please?
Yeah, so this is a patient who came in and had undergone treatment with triple combination therapy, and she was very compliant and had no benefit. And so in this case, I actually went ahead and just put her on the treatment regimen, maintained topical therapy, and started microdermabrasions and low fluence Q-switch YAG laser treatment. And this is her appearance after several treatment sessions. So I think she had 3 or 4 treatments, and she maintained her benefit for about a year from this combined modality.
Okay, and one more here from Ariel.
Yes, and this was another individual, again, a trial of topical therapy without adequate improvement. And she was actually treated with a combination of a Q-switch YAG laser and a long pulse KTP laser. In general, so this can be used, and I will use a long pulse KTP only in type 1 or 2 patients, but really my workhorse for vascular laser in individuals with a clinically significant vascular component with melasma is going to be the pulse dye laser.
Okay. Just in the interest of time, we'll take this one more here, Ariel, and then we'll stop with this one. This is another great result here.
Yeah, and this is really just another example of microdermabrasion and Q-switch YAG low fluence, and this is after 2 treatment sessions. And and she was also refractory to topical therapy. I guess I just wanted to make a comment, and that is that all patients, almost all patients, when I say refractory for treatment or no response, all patients improve with topical therapy. I think the issue is how much improvement do they get? So if a patient has 40, 50, even 60% lightening after adequate topical therapy, are they going to be satisfied with that? And that's where I think laser really comes in, because we can take them to the next level. I guess based on experience, it would seem to me that what's lacking in the topical therapy is that we have no way to eliminate the melanophages that are sitting in the dermis, because topical therapy won't do that. We could decrease melanin production, we can remove epidermal melanin, but how are we going to use other modalities to selectively remove dermal melanin? And that's where I think the beauty of laser is, if it's used correctly, is we can disperse that dermal melanin or remove telangiectasia. And that's where I think we get our patients from a, quote, statistically significant response to an excellent response.
Well said.
Okay. And that's excellent. I wish this could keep going on, because I know we have some more cases, but we're running up against hard to imagine, but we've been here for 2 hours now talking about melasma and almost all aspects that I could think of. And I really want to thank everybody who stayed with us on this Thursday night for the whole time. There are a lot of people that stayed on. There are a ton of questions and really good ones, and some questions a lot about different products and settings and so forth. And I think what we're going to try to do is just answer those offline as best we can. So we will triage those and answer them. And I know that the other speakers we are on social media, and you can join us there if you have questions. But I really would like to thank the panelists. I just don't know what to say. You guys have worked hard. It's been some trying times this week, and everybody has still managed to deliver an unbelievable session here. And I think this may be one of the more popular sessions I've attended, and I know why. It's because of you. So I want to thank you, and then I know all the panelists want to thank Candela, because the freedom and the forum to talk about all aspects of melasma just hasn't been possible before, with medical therapy, chemical peels, everything. So we really appreciate the opportunity to present this. And if any of the panelists have anything they want to add, I'm just going to say thank you.
I just want to congratulate you on an outstanding program. And I mean, just looking at all these questions, I mean, I think there's over 200 questions. Obviously, you have found an area where there is a tremendous amount of interest and need for education. And so I just want to congratulate you and Candela on such an outstanding program.
Yeah, I'd like to thank you all. Learned a lot from everybody.
I agree. This was excellent. Thank you so much.
And I learned a lot tonight, too, and I want to thank Candela and all the other panelists.
Well, thank you. I'll turn it back over to Kanika. Yeah, please. Thank you.
Yes, thank you, Dr. Munavali, and thank you to our panel and all our guests. I think this could be a semester-long course, and everybody would be really happy and enjoy the entire duration of it. So on behalf of Candela, thank you all for joining tonight, and thank you for participating in our virtual meeting. Just a reminder that we will have additional educational programs all throughout the rest of this year, and we will continue to provide you with great learnings and discussion with our key experts. Please do sign up for any of our programs at candelamedical.com/NA/events. And again, have a good evening and a good day, no matter where you are. Thanks very much.
Okay. Thank you, everybody. We're going to sign off now.
Thank you.
Good evening. Thank you.
Good morning, yeah.
Good morning.
Yeah.